Good afternoon, everyone. Welcome to Medical Grand Rounds. I'd like to make a brief land acknowledgement before we begin. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Just a reminder to please enter your questions in the chat. You can leave them please till the end of the presentation and enter them in the chat. As well, please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today. And finally, our speakers today are courtesy of actually the Division of GIM and the Division of Medical Biochemistry. And I would like to invite Dr. David Blank, the Chief of Medical Biochemistry, to introduce our speakers. Thank you, David.
Thank you. Good afternoon, everyone. One of our roles as a medical biochemist is to ensure that we provide appropriate testing. So, in other words, to stop offering tests of low utility and bring in new tests to better serve the needs of our population. However, this has to be done within the constraints of our healthcare system, and to that end, we need to work very closely with clinicians to identify and justify the introduction of appropriate new tests and lobby the different levels of administration to have these new tests introduced. So today, Dr. Grunbaum and Malhamé are going to provide you with a window of one such collaboration. Dr. Amy Grunbaum is the Chief of the Division of Biochemistry for the MUHC Department of Laboratory Medicine. He's also overseeing in the Glen lab the TDMs. He's a McGill graduate, and he has his Royal College certification in medical biochemistry. His clinical and research interests are in the development and implementation of clinical biomarkers and bone metabolism. And he also co-directs the Bone and Mineral Metabolism Fellowship program in the Division of Endocrinology. Dr. Isabelle Malhamé is a clinical scientist and an assistant professor in the Division of General Internal Medicine at the MUHC. She specializes in obstetric medicine. Her program focuses on reducing severe maternal morbidity, including from preeclampsia. Her work has been supported by the FRQS, the CIHR, Canadian Foundation for Women's Health, and also the Heart and Stroke Foundation. In 2022, she received an early career investigator award from the Gardner Foundation and a Canada Gardner Award in recognition of her research on improving maternal health. So I'm now going to turn the floor over to both of them to talk about how biochemistry and maternal medicine, this collaboration has led to, or will lead to, and improved diagnosis and management of preeclampsia.
Thank you, David.
Thank you.
So, yeah, this is our topic du jour, the angiogenic biomarkers in the management of preeclampsia. And in terms of our disclosures, I don't have any to declare. Isabelle, well, it's pretty straightforward. I think she's pretty clear of any conflicts as well. So you all received our educational objectives of the day. It's to summarize the pathophysiology and the clinical manifestations of the disease, preeclampsia, to discuss how angiogenic biomarkers, you'll hear about SFLT and PLGF, can help establish a diagnosis of preeclampsia, and discuss our progress towards introducing these tests into the Quebec repertoire. So one question, and I think David highlighted as well, is why is a biochemist who, David already explained, my interests are in bone metabolism, not preeclampsia, not pregnancy. What do we have here to say today about preeclampsia? So to set the table a little bit, back when I came back to the Glen in 2020, and everybody was all up in arms about COVID, that's when I got to meet Isabelle. And Isabelle, hearing that she had a little bit of a window into the lab, made full use of it. As anybody who knows Isabelle well, is she's not going to let go once she has something. And so this idea about angiogenic markers, preeclampsia, tests that are on the horizon. Why aren't we doing them here? So we started investigating it. We made our own application to the INS and M3S. The submission process in Quebec is quite different from the rest of Canada. And it's taken about 4 years to have the tests come to light or be accepted into the repertoire, which we'll describe a little bit at the end. Um, introducing new tests, making sure that we have access to the proper diagnostic and prognostic measures that we need in the lab. This, in our current era with the Santé Quebec and which I guess I can only politely call austerity measures, it's difficult. And it's really the lab and the lab clinicians, the lab physicians can only do so much. We really need to have clinical support, the support of clinicians in order to push tests forward. So here is one example of where we collaborated well, and we're still pushing forward with it. One advantage in Quebec we have over the rest of Canada, to be fair, is that once a test is accepted for use in Quebec, it's accepted across the province. For example, in Ontario, it's hospital specific. So if Sunnybrook has happened to be able to push through this preeclampsia testing, it's really only available to Sunnybrook patients. Where Quebec is a little bit ahead of the curve is that once a test is approved, theoretically, it should be available to everybody across the province. So with that, I'll let Isabelle talk a little bit about the background and clinical manifestations of the disease.
Right. While perinatal death from preeclampsia has decreased, the incidence of preeclampsia over the past 10, 20 years has been increasing in Canada and in Quebec specifically. So this is a timely topic. We're seeing more and more individuals getting diagnosed with preeclampsia, and this is probably related to underlying risk factors in the population, which have evolved over time. So as you know, in the general population, we're seeing more and more risk factors such as maternal age over 35, obesity prevalence increasing, cardiometabolic complications such as pre-existing chronic hypertension, as well as pre-existing diabetes and type 1 and gestational diabetes, which are all risk factors for preeclampsia, and more use of reproductive technologies, which are associated with an increased risk of preeclampsia. We're also getting better at diagnosing it, and the diagnostic criteria have widened. So we're capturing more and more cases of preeclampsia. We can go to the next slide. Preeclampsia, as you can see globally, really remains a leading cause of maternal mortality. We still have hemorrhage that surpasses hypertension, but preeclampsia for pregnant women remains an important danger. And so it is really important for us to be able to diagnose it early and to manage it appropriately to reduce that risk going forward. Here you can see the increasing prevalence of the different risk factors that I mentioned. So our knowledge and understanding of preeclampsia, because of an increasing prevalence, but also because of time and interest growing, really has evolved. And you can just see the record of the number of publications that have exploded in the past 10 years, with more and more of an interest to understand the disease better, to characterize its risk factors, and to prevent it and diagnose it better. And so we know of some clinical risk factors, so we can always identify who are the women at higher risk around the first trimester to be able to maybe predict, but at least understand who's our high-risk population. And so the SOGC, so the Canadian Society of Obstetrics and Gynecology, has outlined a few high-risk factors as well as moderate risk factors. And this is particularly important for members of the Department of Medicine because many of those conditions will be found in your patient population of reproductive age. So of course, previous preeclampsia, chronic hypertension, chronic kidney disease, diabetes, systemic lupus erythematosus, as we mentioned, and antiphospholipid syndrome, pre-pregnancy BMI above 30. So that's really a risk factor that is quite common in our population, assisted reproductive technologies, and moderate risk factors, meaning that a combination of those risk factors place women at higher risk, including maternal age, nulliparity, multifetal pregnancy, so twin pregnancy, triplet pregnancies, prior placental abruption, which symbolizes an underlying risk for malplacentation, prior stillbirth, and prior fetal growth restriction. So we can anticipate a little bit who will be getting the disease and who will be who will need preventative measures, but these risk factors alone are not sufficient, and we can't really predict very well yet this risk. And so there's a lot of interest to better predict the disease. Moving to the next slide. So with these different risk factors and risk markers, such as the genetic predispositions, the maternal characteristics, the comorbidities that we've mentioned, the placental disease, the immune factors, and the multifetal pregnancies, we know that this will lead to, at the very beginning, a problem within the placenta with impaired placentation. And these early vascular problems within the placenta, which really start at the beginning of the pregnancy, are truly the genesis of this syndrome, which will manifest much later. And it's important to understand this pathophysiology because the biomarkers that we're presenting today are directly linked to that pathophysiology, whereby because of these multifactorial risk markers and this poor placentation, there is a release into maternal circulation of anti-angiogenic factors, and the balance of pro-angiogenic and anti-angiogenic factors becomes skewed towards a vasculotoxic environment where you have systemic maternal endothelial activation and vascular injury that manifests with hypertension, as well as other manifestations. And Ami will walk us through that a little bit more in detail later. So for the next slide, to have a diagnosis of preeclampsia, and I know some of you may not be super familiar with the diagnosis, and that's totally okay, and it has changed a lot over the last few years. Yes, we still are talking about a hypertensive syndrome, so you want to be diagnosing hypertension after 20 weeks of pregnancy, so a hypertension that is de novo or hypertension that is present after 20 weeks of pregnancy, with systolic blood pressure of 140 and over 90. And these blood pressure thresholds have not changed. So we're still talking about 140 over 90. And with an increasing use of home blood pressure monitoring, we may have more flexibility around what constitutes high blood pressure at home, but still in office, we're using the 140 over 90, averaged twice over 15 minutes after 20 weeks, with evidence of end organ damage. So end organ damage, yes, that includes the classic proteinuria, so which has been taught for a long time. Preeclampsia is hypertension and proteinuria, but we're now recognizing preeclampsia as a truly multi-systemic disease that will have one or more adverse conditions that can affect pretty much any organ of the body. So moving on to the next slide, I will convince each and every one of you in the Department of Medicine that this is a disease that you should all know and that you should be comfortable with the different manifestations, or at least with recognizing that this might be preeclampsia. So talking about the central nervous system, severe headaches and visual symptoms, all the way through PRES or cortical blindness and retinal detachment and coma are within the spectrum of preeclampsia. And we kind of divide the manifestations with regards to whether or not they're an indication for immediate delivery. So it's kind of important to know what these entail. For cardiorespiratory, so for all of you respirologists and cardiologists in the room, chest pain and dyspnea with desaturation, these are definitely clues that there might be underlying pulmonary edema or myocardial injury in the context of preeclampsia. Hematology with low platelet counts and platelet counts below 50 are manifestations of preeclampsia, and you can ask the many hematologists I have had the opportunity of speaking with over the past few years to really try to get to that smear and look at if there's mechanical evidence of hemolysis and whether there is a TMA going on with preeclampsia. So definitely have involved this group, as well as renal with elevated serum creatinine and acute kidney injury. And it's always difficult to say whether this is preeclampsia or if we're talking about another potential additional ongoing process, such as an infection or someone who's having lots of nausea and vomiting or anything else that could trigger AKI. And how do we really tell if it's preeclampsia versus the other disease? So the nephrologists have been involved in that setting. The hepatic manifestations as well are difficult to disentangle. Of course, you have the right upper quadrant epigastric pain, typical of a HELP syndrome, but sometimes you just get a little bit of elevated AST and ALT without having the full, the full-fleshed HELP syndrome, and it's also a challenge to understand whether this is preeclampsia or otherwise. And of course, the only organ that we'll have in pregnancy is the fetal end organ damage. So uteroplacental dysfunction is a hallmark of preeclampsia. And so it's really important when you're assessing these patients to also have a look at what the Dopplers are going to show, and what the obstetrical ultrasounds are going to show. So I hope I've convinced you that it can be tricky to diagnose, and all of you may get involved at one point or another to help in the management of a patient with preeclampsia. And I'll pass it on to you, Ami. Thank you.
Thanks, Isabelle. So yeah, that's my cue. What can the lab do to try to help out over here? And this is where we get to the angiogenic biomarkers, and we'll hear about SFLT and PLGF now. Maybe I'll just rehash a little bit what Isabelle was explaining about the pathophysiology. So on this cartoon over here, what I'm trying to highlight is that in normal pregnancy, blood flow from the maternal blood flow to the placenta and the fetus, it's going through the spiral arteries for the most part. What's happening in preeclampsia, there's a predisposition before the onset of preeclampsia. The problem is more with the remodeling of these spiral arteries, and there is a decrease in blood flow. This decrease in blood flow will lead to placental ischemia and an oxidative stress, disrupting the placental development. And with the distressed placenta and this placental development, there's this release of these angiogenic factors, or altered release of angiogenic factors. We have the placental growth factor, which is the proangiogenic protein, along with VEGF and others. We also have what we'll call soluble FLT, or soluble VEGF receptor 1 is the other name for it. So what we have going on here in the normal setting, normal development of the placenta, the fetus, the pregnancy, is PLGF and VEGF bind to the different VEGF receptors. There's VEGF1, VEGF2, VEGF3. FLT1 is VEGF1. Normally, PLGF and VEGF will bind to FLT1, and it's proangiogenic in that setting. In the altered setting, there is this increase in soluble FLT1 or soluble VEGF receptor. These will bind to VEGF in the circulation, and as such, they're not allowing the endothelium to relax. There's more of a vasoconstrictive effect. So what do we have with that? The altered concentrations of SFLT1 and PLGF, or placental growth factor. This is a study back from 2004 by Levine that was published in New England Journal. And their study actually was based on a large cohort of patients that were in the CPEP trial back from the early 90s, calcium, and the preeclampsia trial. Well, I guess everything gets back to bone and calcium at some point. So here, this is where it started. Based on they had a trial of about 5,000 nulliparous singleton pregnancies. They did a nested control on that, where they selected out 120 patients that ended up having preeclampsia and 120 controls. They had collected bloods during the pregnancy, and then they, at multiple time points, and they went ahead and analyzed them on like a post hoc analysis. And this was published in 2004, about 10 years after the CPEP trial. So what we see over here is that the SFLT, the anti-angiogenic marker, the black line is what happens in normal pregnancy. It seems to climb. It starts off low and climbs throughout pregnancy and peaks just before delivery. On the other hand, what we see here in patients who had PE much higher levels. And even more interesting, the orange line, for women that would go on to develop preeclampsia later, even as much as 5 weeks before the clinical onset or clinical manifestations of preeclampsia, you can see a change in the SFLT levels. Similarly, if we look at the PLGF, PLGF is a little bit more it peaks and valleys. So if you look at the black line, PLGF increases throughout pregnancy and tends to drop off as you get to term. Again, if you look at the blue line over here, these are preeclampsia patients, and they have, in contrary or in opposition to what happens to the SFLT where it increases, the PLGF in these women is decreased. Again, what's quite interesting is that the decreases in PLGF happen in women who will later have preeclampsia way before their clinical manifestations. And whereas SFLT seems to drop about 5 weeks before the clinical manifestations come out, PLGF changes, or SFLT climbs 5 weeks before, PLGF changes to drop happen as much as 10 weeks prior to the onset of the clinical symptoms. So here's another graphic, just giving you a little bit of a nicer look at the ratio of SFLT to PLGF. So the ratio tends to stay quite constant through pregnancy, but in preeclampsia and intrauterine growth retardation, restriction, sorry, there is elevation as we get to about 5 weeks before the symptoms develop. So this led to the idea of testing for preeclampsia. And there's two areas, there's two time points that we're looking at. First is within the late first trimester, early second trimester, so about 11 to 15 weeks. There's this idea about screening for early onset preeclampsia with PLGF. This is not something that we're going to talk much more about. We're really looking at short-term prediction and diagnosis of preeclampsia. So this is happening from 20 weeks on. Okay? And what we see from 20 weeks on, again, some definitions: early onset preeclampsia is preeclampsia that manifests before 34 weeks, or at 34 weeks or before of gestation. Late onset is 34 weeks and on. And what we're looking at is starting to help out with the diagnosis and predictions from 20 weeks and on. And the tests we have to look at over here are PLGF, SFLT1, and the ratio. So back about 10 years ago, there was a study, these studies by Verlohen's group out in Germany. They were looking at establishing cutoffs for the diagnosis of preeclampsia. So these were done on singleton pregnancies throughout Europe, 9 different centers. Their study was based on 234 cases of preeclampsia and 468 matched controls that had normal pregnancies. And what they established was the rule-in and what they called rule-in and rule-out cutoffs. So based on the SFLT to PLGF ratio, they were comfortable ruling out a diagnosis of PE with a ratio below 33, and ruling in at a ratio above 85. So they had this bimodal idea. What you do in the gray zone, well, that's more difficult to interpret. That lays where the clinicians become involved. And these tests had quite good sensitivity and specificity for the early gestational phase. The late gestational phase was a little bit less solid, but still quite good in terms of sensitivity and specificity over what we have with the other clinical markers, what we are using. Yeah. From there, we'll move on to what we call these predictive testing or predictive algorithms. Back in 2016, there was the first publications out of the prognosis study looking at short-term prediction of preeclampsia. This again was a multi-center observational trial looking at prospectively. They had recruited about 1,000 pregnant women. Of those, 200 ended up developing preeclampsia, And they split these into development and validation cohorts. And they were looking at from 24 to 37 weeks, measured both SFLT and PLGF at weekly visits. And they ended up we showed these raw curves of sensitivity versus specificity, again, with quite good area under the curves. They were saying with a value of 38, a ratio of 38 of SFLT to PLGF, they were able to rule out preeclampsia within 1 week with a negative predictive value of 99%, over 99%. Alternatively, to rule in preeclampsia within 4 weeks with a positive predictive value of about 37%. The idea being here that if you see somebody run the test and they have a value under 38, you could quite confidently say that they are not going to develop preeclampsia within the week. Here's just a different cartoon of showing how what they were giving prediction or you were publishing. So a negative predictive value of 99% for ruling out within a week, and a 37% predictive value, positive predictive value for ruling in within 4 weeks. Post hoc analysis, they were looked at trying to say, well, how does this fit with how does this advance with our clinical data? So if we use the ratio or the diagnostic or the prognostic test along with the clinical data at hand. And what they said is, without using the lab tests, they had a 75% area under the curve. Incorporating the lab test, they were able to bump this up to 86% for a 1-week rule out. Alternatively, ruling in preeclampsia within 4 weeks, 80% without the lab test, up to about 90% with the blood test to rule in. Sorry, we're talking about AUCs, not prognostic values here. So the next part of their post hoc analysis is like, okay, we're pretty comfortable saying we can use this test to rule out the disease for a week. Can we extend this out? What happens if we want to, what's the chances that these women are going to develop preeclampsia within 2 weeks, 3 weeks, and 4 weeks? We see that the negative predictive value does drop the farther out we go, but it still says it's still pretty solid. Okay, another study they did, another group was the pelican study. I mean, I don't know, these obstetricians, they love their birds. There's the pelican study, the parrot study, the magpie study, and then they get into peach study and apple study, but that's for another day, I guess. So the pelican study, here we're looking at a different test. We're looking at just the PLGF. And to give you a little bit of insight into the lab, the SFLT PLGF ratio is what's being championed by Roche Pharmaceuticals and Roche Labs. PLGF does exist as a standalone test on other platforms such as the Quidel Triage. And that's important when we get to see how we can offer the test throughout the province. So the Pelican study was based on this PLGF almost point of care test. And they had similar findings. There's nuances here. They looked at a 14-day prediction versus a 1-week prediction that the prognosis study was looking at. And they only looked at earlier pregnancies, so before 35 weeks. But they did show that there was, again, a good negative predictive value for ruling out the test in short term. And positive predictive value for ruling in the test was more troublesome. Here we look at, again, adding the added value of these lab tests to the clinical data. And so we see here, if I'm not mistaken, this is what happens when you have just the clinical information. In this case, it's the blood pressure, uric acid levels, and the ALT, which gives you an ROC of or an AUC on the raw curve of about 0.7. If you combine these tests with the preeclampsia markers, you get the AUC up to 87. So yeah, these are diagnostic and prognostic tests done as observational. What happens if we look at the clinical trials to date? And I'll try to summarize two, the INSPIRE and the bird named Parrot study. So Parrot, which were the initial results for this were released in 2019. It was a UK study done in 11 different centers, and they used that triage PLGF point of care test with a cutoff of 100 nanograms per liter. So 100 is the cutoff on the PLGF test. They looked at suspected preeclampsias between 20 and 37 weeks. And they split into two groups, the revealed and the concealed arms. So in the revealed arm, the clinicians managing these patients had access to the lab test results. And in the concealed arm, they were going just by the routine markers, routine care. And what they found was that the time to diagnosis was dramatically reduced, or significantly reduced, I shouldn't use the word dramatically, significantly reduced from 4 days to about 2 days. Adverse maternal outcomes, the incidence of adverse maternal outcomes, again, was reduced from about 5% to 4%, with serious adverse events dropping down significantly again from 1% to 0 in the revealed arm. For the perinatal outcomes, I don't think there was much of a significant difference for the fetus or the neonate. Here, just some more test characteristics. So again, looking at the NPV, again, about 98% or 97%, less than 35 or more than 35 weeks. The positive predictive values to rule in the disease, not doing as good as ruling it out. And the other trial that I'd like to talk about quickly is the INSPIRE trial, also back in 2019. This was, again, in the UK, based on a single center in the Oxford area. They had 360 patients with suspected preeclampsia. Again, they split these into two groups, the revealed and the concealed arms. Of the 360, there were 85 that ended up being diagnosed with preeclampsia, again, split quite evenly between the two arms. For their primary endpoint in this study, which was preeclampsia-related admissions, there wasn't any difference. In terms of secondary endpoints, this is where it gets interesting. They found that they were able to improve on what they called adequate admissions. So if you had access to this test, anybody who needed to be admitted was admitted. So 24 out of 24 patients who would develop preeclampsia within 7 days were admitted. But in the concealed arm, 3 out of 18 or only 8 were sent home, were left to go home. So 83% adequate admissions for development of PE within 7 days. They also commented on a trend towards faster preeclampsia diagnosis. This didn't pass statistical significance, but it seemed to trend that if you had the revealed group, they had the appropriate diagnosis of PEs done within 7 days versus 9.5 days in the concealed arm. And lastly, the admissions from the revealed arm were more likely to have significant complications. What do we mean by this? Well, this was more difficult to interpret for me, being on the outside looking in at this clinical area. But again, there seems to be a trend where the revealed arms, they gave you a better sense of who was at risk, who was going to go on and develop significant preeclampsia or significant manifestations of disease. So in the revealed arm, the birth weight of the patients was lower than in the concealed arm. The APGAR scores were lower. Requiring special care baby unit, which I think is more like a NICU admission, was more likely in the revealed arm. Small for gestational age was also more likely, and the gestational age of delivery was a little bit younger. None of these, except for the first one we already talked about, were statistically significant. Maybe the study wasn't powered strongly enough to really reveal this, but from what I understand, a lot of clinicians, a lot of champions for these markers have used the Inspire as some evidence that there is benefit to these tests. So the first Canadian study that came out was out of Toronto, Sunnybrook. So Sunnybrook has been offering for its select patients in its clinical graphs, SFLIT and PLGF testing for the last couple of years. They released their clinical validation study about a year or a year and a half ago now. So what they did, they had 130 samples. They measured both markers on their Roche machines. They had the diagnoses verified clinically, and they found that about 46 or 35% of their patients diagnosed with preeclampsia. Their validation study, again, their diagnostic accuracy, their negative predictive value were quite in line with what we had been talking about so far. They also looked at clinical evidence with and without and using the lab tests or the angiogenic biomarkers, and they found that the negative predictive value, if you were using hypertension or proteinuria versus combining it with the biomarkers or the angiomarkers was significant, was improved. So what do we have available now in Canada? We have the Roche testing, both SFLIT and PLGF, and what they're pushing with their ratio. We have the triage, and this actually the Roche assay is probably the one that's best studied to date. And there we have the Verlowen study and the prospective study, the Sunnybrook study, the Inspire trial. They're all based on this Roche assay. Triage, PLGF, well, there's the Pelican study and the Para trial. This actually was licensed for use in Canada within the last year, I believe. What's interesting about this test is compatible with point-of-care platforms. So in Quebec, we'll get off topic for a second here. If you ask me what delayed bringing the test into Quebec was, in Quebec, we're a socialist entity. We want to make sure that everybody has access to these testing and as equitably as possible. It's hard to get just the Roche tests up into all areas of the province. So if we're talking about up north, they don't have the Roche instrument. We need to get this test done to them in a finite period of time, a reasonable turnaround time. It's difficult. The triage is a small device, which is also marketed as a point-of-care device. It's available, can be done in remote centers, and once this came on the market or was approved by Health Canada, I think that opened the door for preeclampsia testing in the province, and that's what kind of helped accelerate or took the brakes off this project. So we have the Roche assay, the PLGF triage assay. You also have another Delphia Express PLGF, which there's not a lot of literature on. There was a lab comparative study, aptly called the COMPARE study, that compared the Delphia triage and Roche assays. And you also have the Brahms Cryptor method, which is less evaluated, less studied. There was a recent study came out in 2022, US-based, quite large, quite extensive. Their ratio, again, falls in line with what we've been seeing with the Roche assays and the PLGF based assays. Finally, one question that comes up to me is there added value to doing both SFLIT and PLGF? Can we get away with just doing PLGF? What's the added value of combining these tests? That's less evaluated, to be honest. The companies, the vendors don't have much interest in really pushing this, I don't think, especially Roche. Roche is really trying to push their ratio. This is what I was able to find out of the prognosis studies, the Verlaine studies. Sunnybrook did a small comparison. I'll leave it to you to decide. It seems that S-FLIT does better than PLGF. S-FLIT combined with PLGF does better than PLGF. In the real world, are we going to need to have both tests, or can we get away with just one or the other? I think it's too early to say. We'll have to see what works in our environment with our patients, and this is something, I think this is an area that will provide a lot of opportunity for investigations with our cohorts. Finally, before I hand over back to Isabelle, what's the advantage for the administration and for the bottom line? So there have been quite several studies out of Europe that have shown that if we look at the big picture, we can save a significant amount of money on the healthcare budget by introducing these tests. Unfortunately, in Quebec, we tend to take a silo approach. The lab budget is increasing, so that's no good. But if you take a global approach, if we're able to influence hospitalization rates, and if we're able to use this as a negative predictive test, do the test, and somewhere along the lines of maybe what we thought about for BNP or NT-proBNP, do the test. If it's negative, we're reassured we can let the patient go home. You can see here in the UK, with the test, they were able to drop down their hospitalization rates by 20%. Italy also, Germany, and there was significant savings per patient. A little bit of a back of napkin calculation that we included in our M3S submission was that if done properly, we may be able to save a significant amount of money for the province by reducing hospitalization rates and assorted diagnostic or measures. With that, I'm going to hand back over to Isabelle to talk a little bit about the guidelines that have been created and that we've been working on a bit.
Thank you so much, Ami. So I'll go to the next slide and show everyone that as of 2022, we have actually the Canadian Clinical Practice Guidelines for hypertensive disorders of pregnancy that really does support the use of PLGF-based testing, so including PLGF and the combination of S-FLIT and PLGF, to help in the diagnosis of suspected preeclampsia. So this is what's written in the guidelines, and how to take this and make it a reality. I hope that Ami has conveyed the level of complexity, the multifactorial assessment that comes into play, including the multiple dimensions in which we need to show a benefit. And that goes way beyond just saying that the guidelines support the use. And so I'm really thankful and grateful that we've been able to do this in partnership, because really clinicians alone, I don't think can get any of this and move the care forward and innovate forward without the support and without the leadership of the biochemistry group. So I'll move on to the next slide, and we'll skip the next slide as well in the interest of time. Next slide, and go straight to our INES recommendation. So I think I speak for both Ami and I saying that we're very proud of the recommendation that we're showing to you here, because this whole process started back in 2021, and in 2024, INES actually recommended to the ministry to introduce these tests in the repertoire and to make them part of our clinical arsenal. And I think that just goes to show a bit of our McGill pride and our McGill leadership in this process. And we are a center of excellence for hypertension. Dr. Daskalopoulou, who might be on this call, and many other collaborators have shown this in terms of having a world-class team for precision hypertension, as well as a research network that supports hypertension research. And so I really feel like this is representative of how much of a leading group we are in Quebec in hypertensive disorders, and including in hypertensive disorders of pregnancy. Moving on to the next slide. And so in order to provide INES with a clear framework for the interpretation of the introduction of these tests, we needed to really agree on how we would be using these tests, because a test such as this one has a little bit of a potential to become like the new procalcitonin, or the new anti-proBNP used in the wrong way. You have a potential where people can be falsely reassured by a low value if interpreted incorrectly, and people can actually have a lot of anxiety, or a lot of repeat testing, and a lot of wasted resources if the use of the test is not being guided judiciously. So we really wanted to provide a very clear pathway for our provincial use. And so this led to an organized conversation, a little group discussions among different individuals in Quebec who have a lot of clinical expertise in diagnosing preeclampsia. So we really wanted it to be a clinician-led process. We gathered an interdisciplinary group of physicians, really clinicians, that represented the specialties of clinical biochemistry, GIM, obstetric medicine, nephrology, obstetrics and gynecology, so general OBGYN, and maternal fetal medicine. And we wanted to have representation from 4 universities in Quebec. So we were leading the approach in McGill, but we wanted to make sure that this was inclusive of the 4 other RUIS. And we wanted to have representation from members of the following professional and scientific organizations. So l'Association des médecins biochimistes du Québec, l'Association des gynécologues obstétriciens gynécologues du Québec, le groupe de médecine péto-maternelle du Québec, and le groupe d'études en médecine obstétricale du Québec. So we wanted this to, be a comprehensive clinical approach. And moving on to the next slide. We met twice back in March 2023 with 2 times 2-hour meetings with pre-reading materials on all the clinical trials, summarized ahead of time and provided to the different attendees so that they could get a sense of the literature surrounding these biomarkers. The discussions that we were having were being transcribed in real time with note-taking using a virtual whiteboard. And then we used a consensus-based decision-making process to develop our proposed utilization of the test based on a few questions that were asked to generate more discussion. And our discussions were summarized in a briefing document. So really what it boils down to is this table and the following 2 figures that we'll show. The test is to be used in singleton pregnancies between 20 and 37 weeks for people with suspected preeclampsia in the context of a partial or an atypical presentation that does not currently meet SOGC criteria for preeclampsia. So it shouldn't be used in people with established preeclampsia. It shouldn't be used if for any other type of indication than seeing whether or not someone has preeclampsia, because we're just not sure what's going on. And it's used as a help. It's not, as always, you need to put it into the greater global clinical context, and how to interpret the result is really within the clinical setting. And we favor the use of PLGF-based testing alone. We do not have any type of partial, we're not partisan for one test more than the other because of anything else than the fact that back in March 2023, when we were writing this guidance, the only test that was supported by Health Canada that had a clinical trial with proven clinical benefits in their use was the Roche test. So this is why our proposed algorithm focuses on the S-split to PLGF ratio, but it's really reflective of the current literature available at the time. And we're planning to upgrade our guidance based on the newly accepted test, which now includes the triage PLGF alone test, which was not available at the time, and that has good clinical trial data to support its use. The diagnostic thresholds that we adopted were the ones that were recommended by the Health Quality Ontario group, as well as the NICE guidelines in the UK. So we did not make those thresholds up. We used guidance that was already available, and we reiterated that they needed to be interpreted in consultation with a specialist to understand what they mean in the context of a very high risk profile. So moving on to the next slide. This is the French version. We'll go to the English version in the next slide. So essentially, that's how we propose to use the test. If you have a ratio that's under 33, the patient is considered right here, right now, at low risk of having preeclampsia. So not or prediction of adverse outcomes, really as a diagnostic test right here and right now. And so if you are in that category, we would recommend continuing follow-up as recommended by the national guidelines for the management of hypertensive disorders of pregnancy based on your underlying risk factors, which are the clinical risk factors that we presented at the beginning of the lecture. Then if you're in the gray zone, so depending here, there's a little bit of a dichotomy depending on whether you're early preterm or preterm, when you have an intermediate probability. So if your testing results, in that gray zone, the patient is considered at intermediate risk of having preeclampsia. So it's like you don't not have preeclampsia, but you don't really have preeclampsia. You're kind of in that brewing, not too sure how it's going to go zone. And so we would recommend really close follow-up, again, based on guidelines that would, mean repeat assessments with blood pressure and biomarkers that are not necessarily the angiogenic biomarkers, but the regular biochemistry testing, and consider consultation with a specialist because you're in that orange zone of brewing your preeclampsia. And then if the test comes back positive as above 85 or above 110, you're considered at high risk of having preeclampsia right here and right now. And so again, what defines a disease? It's not a single test entity. It's really in the clinical context in which you tested with that test that you could have, it's a very high probability that right now you have preeclampsia and you should be managed according to the clinical guidelines recommendation. So with that in mind, this is how we framed our approach to INES and refined it further during the publication process. And I'm really pleased to share that others have used this algorithm and will be inspiring themselves from it to use it in their own hospital. And Ami, I'll give it back to you for the conclusion of the presentation.
Thanks, Isabelle. That was great. I just want to call back to this slide for a second because this is also this was also in the proposalization that we had in our paper that you helped push through, Isabelle. What we have over here about pas de données justifiant de répéter le test in most conditions. And I think here, this is important to highlight. And this is something else that came out in the recent extension of the Pelican study, I think, or Parrot study, the Parrot 2, where they were looking at repeated testing after the initial PLGF-based test. And from what I can garner, there's limited support for repeat testing once you have either a positive or a negative PLGF-based test. It's not something that has to be repeated in most situations. So again, that's for guidance on how to use the test and how to try to limit the impact on our budgets. So yes, what we're happy with is that this test, as of about 2 weeks ago, April 15th, it was a nice birthday present to me. It was newly introduced into the Quebec repertoire. It's been, that being said, there are still some challenges that remain. We need to implement a test locally. We have to convince administration and bureaucrats that we need this test, both at a hospital level and also within the regional and M3S level. There's a lot more paperwork that has to go through. There's a lot more purse strings that have to be loosened. But hopefully, with everybody's help and with the clinician support, we can advance this quickly. Thank you all.
Thank you so much. A terrific presentation, really an excellent example of how lab and clinical people can come together. In your case, a multidisciplinary group of people when you look at all those people on your panel. Congratulations also on all the work that has been done here at McGill to advance the literature. We have a couple of minutes for questions, and I see that the questions are coming in, so I'll get straight to that. Dr. Rosenblatt is asking, in the real world, do you think that many family doctors or obstetrician will want to test every pregnant woman at 20 weeks as part of the routine? And do you have any feel for the volume of predicted test requests in Quebec over the next 3 years?
Isabelle, you want to start with the first part?
Well,
I'll go with the second part.
exactly. Yeah. So for the first part, it really isn't indicated to use these tests right now as screening tools. We're introducing them as diagnostic tests and not as like screening to discriminate between high-risk individuals and not. And this is a great area for further research, but for clinical purposes, we really wanted to stick to clearly a diagnostic test, and we'll make it very clear in the ordering algorithm what are the indications for testing. And Ami, for the estimates, I'll leave it up to you.
Yeah, there have been some estimates. We provided estimates to the to Ines about what we think of volumes would be like, and I don't have them in front of me, and I'm trying to remember what they were. I have to dig it up. It's limited. We don't expect it to explode, and the reason we expect it to stay within reason is number one, this test we see it being ordered by specialists in cases of suspected preeclampsia. So not, as Dr. Rosenblatt was alluding to, anybody who has a 20-week pregnancy and on, it would be cases that had suspicion of preeclampsia to help, as Isabelle says, diagnose it. So by limiting who gets access to the test, under what conditions the test, and not repeating the test once we have it negative, we should be able to keep a cap on the number of tests being done. How many, how fast, how much? I think, again, back of napkin, we thought that for the MUHC cluster or MUHC réseau, it would probably cost about $50,000 a year for the test in the setting of the expected savings for other healthcare expenditures.
We have a question in the room here. We only have a couple of minutes left, so a quick question.
Yeah, so congratulations on this innovative work and very good. So I have a question. So at the beginning, you showed quite adequate sensitivity, the specificity of this test, but at the end, the negative predictive value is very good, meaning very good for rule out, but the positive predicted value is quite low. It's a 30-some percent, and for the other one, it's a 50-some percent. So my question is, you said this is for the diagnosis, but I'm wondering whether this test should have never been ordered as a standalone test. It should be always, on the base with the other biomarkers and the other clinical things in a whole panel things instead of for ordering it alone, because the positive predictive value is really low.
And I think look at Dr. Rosenblatt's question is along the same lines about pre-analytics or pre-testing. Can you talk to us about that in about 1 minute?
Sure. I think that's key.
Sorry, guys.
No lab tests, in my opinion, should be taken as the be-all, end-all. It has to be done in the context of the clinical setting, the clinical information. To base your diagnosis or your dismissal of a diagnosis on a lab test, I think is treacherous waters. I know we do it a lot for troponins and MIs, but it's another story, and it has its own caveats. Dr. He or Gang, you're quite right. The evidence here seems to support more ruling out than ruling in. So the setting that I see is you have a suspicion. Are we comfortable to not have to admit the patient or do extensive follow-ups? Can we get away with triaging this patient as a lower risk of preeclampsia? It's not to make the diagnosis of preeclampsia, it's to help rule out the diagnosis of preeclampsia.
And I think we were very attuned to this potential risk and repeated multiple times that this test should be done within a clinical range. And to address one of the questions in the chat, really the ordering physician would need to really mark that there is an ongoing suspicion of preeclampsia, and we would potentially, one of the ways that we could do this, and each center would have their own dedicated protocol, but outline the different potential signs and symptoms that are present, just to make sure that we're on the diagnostic range and not looking for asymptomatic screening.
I'm going to have to close out the presentation. It's past 1 o'clock. There's a couple of little comments or questions left in there, Isabelle and Amy, if you want to just answer those. But once again, first of all, congratulations, terrific work, and once again, really great presentation as a great example of how we can all come together and make these advances. So thanks everyone for joining us. I wish everyone a great afternoon. Bye bye.